always a pleasure to come in and spend time with such great audience. I mean, I don't say patients, I say audience um, because these guys, they are thriving. Most of them are doing amazingly well, and I mean, I think this is the third time that I'm meeting you guys, and every time I meet you guys, I'm just awed by the courage and the strength that you guys show on a daily basis. So thank you. So today we are going to talk about something that is often overlooked. This is something that we kind of like don't pay attention to, or just even as physicians, sometimes we kind of feel that if the scan looks good, the person is fine. But most of the times that's not the case. We overlook this chemo brain issue. And chemo brain can present in a lot of ways. And when we talk about them, one of them being anxiety, I mean, the other being depression. Sometimes it's a combination, sometimes confusion like delirium, and not being as sharp and not being as like kind of like to the spur of the moment, right? And sometimes people cannot sleep. So we'll talk about all of those things. Next slide, please. So this is something when I looked up the data on the internet. I mean, something that came up was like, when we talk about chemo brain, we kind of like put it in like, just like, maybe I'm feeling slow, maybe things are not right. So, but it can present in a lot of ways. I mean, we talked about the four that are primarily the causes of chemo, the outcomes of chemo brain, but we also see a lot of people feeling angry. We see a lot of people feeling fearful, sad, depressed, always tired, not sleeping. I mean, one of them said something like, "I'm a couch potato." So some people feel panicky. Sometimes people feel confused. I mean, they're concerned. Sometimes they feel misunderstood. So chemo brain can present in a lot of ways. Toby, can you hear me better now? I'm trying to speak a little louder.
Yes.
Perfect. All right. So next slide, please. So this is what chemo brain relates to. It's a thinking issue, memory issue that not only happens during the treatment. A lot of people feel it afterwards. Some people call it chemo fog. Your brain is not as sharp. You feel like you're in clouds all the time. Next slide. So again, like we talked about, some people feel very disorganized. Some people feel confused. Some people have difficulty concentrating. One of the things that all of us feel and happens more often after chemotherapy is that some people have difficulty finding the right word. They're just trying to like figure out what it means. Sometimes they cannot learn new skills. They cannot multitask. They get anxious. They get frustrated. They don't have the attention span that they were hoping to have to do a very basic task. And most of the times, I mean, they take longer than usual to complete the routine tasks that they were doing, and that is the most frustrating part, that it just takes longer. Next slide. So whenever a patient comes to me and says, "I'm anxious," or if I'm able to elicit in our appointment that if someone is anxious, we ask a few questions that kind of like give us a yes or a no answer. I mean, the straight question that we ask is, are you anxious? Are you excessively worried about things? And usually for anxiety, I mean, it's about 6 months. We ask if the symptoms are challenging to control, if this is something that is overwhelming you. And the things that I specifically ask for are edginess, restlessness, feeling tired, not being able to concentrate, feeling irritable, feeling muscle aches, not being able to sleep. If someone with the presence of anxiety, with the presence of these symptoms, at least three of them that we talked about, and they're challenging, officially we can say that they're anxious. This is how doctors kind of think through anxiety. These three criteria need to be fulfilled. And then we say, okay, you have a diagnosis of anxiety. Next slide. Now, anxiety can be multiple kinds. I mean, sometimes it's acute anxiety. I mean, I can tell you that when I take my exams, all right, I mean, I'm anxious. When I get called to my HR for some reason, thankfully not yet, I feel anxious. It's acute anxiety, right? So these are things that are very acute, that happen right away, right? So one of the things that happens is that we decide that if someone is having anxiety for less than a month, or in some cases less than 3 months, it's acute anxiety. If it's 3 to 6 months or more than 6 months, we call it chronic anxiety. Why is it important? It's important because treatments for both of them are entirely different. If someone has acute anxiety, we manage this in a totally different way. If someone has long-standing anxiety, it can be managed in a totally different way. Next slide. And I see all the questions at the side, so I will answer each of them at the end. So cancer-related anxiety symptoms that I see are the same ones: sadness, fear, anger, worries about paying bills, cost of living. I mean, something that we are working on right now as a study at CINJ is the financial toxicity that the cancer brings. And we are kind of seeing that people feel worried for a couple of reasons: financial and physics, focusing on anxiety part of it from a financial standpoint. What I see is the person loses their, I wouldn't say livelihood, but the person is not able to work, or if they're working, not as efficiently. Then on top of it, the costs. I mean, some patients told us that the parking costs, the costs of buying grocery, the costs of not being able to cook and having to buy pre-cooked food, that adds up. Cost of the copays, right? They all add up. So this is a huge distress. So this is something that we are working on. And this is something that we are going to be asking a lot of patients in certain ways and saying, what are these issues? Can we kind of focus on them earlier and fix them up for earlier and try to find resources earlier? So that may work for people. Some people, they don't eat, they don't sleep. I mean, this is one of the commonest things that I see. Insomnia, we'll talk about it more. People don't sleep. They're like, I sleep for 4 hours every night. I cannot fall asleep again, right? So there's a fear that there's a fear of impending doom. There's a worry that I'm going to be taken back into this illness. I'm doing so well, right? This is going to come back. So these are all the things that people feel anxiety about, especially after the treatments, especially during the chemo fog that people feel. And if a person is already anxious to start with, they even become worse. I mean, so one of the questions that I ask is that, did you have issues with anxiety before you got chemo? And if you did, there's a good chance that anxiety came back stronger than before. Next slide. So what are the options? What are the things that I can offer as a palliative care pain and kind of like a psychologically focused physician? The first thing is education. We tell people that it's not you. It is the treatment that you're going through. It is the treatment that you've gotten. It is your mind kind of focusing on things that it is just unfortunately kind of like focused on that area, and it should not be. I mean, this is the bandwidth. Think about it as bandwidth. If your brain is focused on anxiety and worry, the rest of the bandwidth that you have focuses slowly on other things, and you're not as alert, you're not as conscious of other things. So that's what happens. One of the things that I tell people for the first time is mindfulness, right? Mindfulness-based relaxation therapies. Everyone has an Apple iPhone or Android phone. There are apps now that you can kind of start working with mindfulness. If not, you can YouTube some of these videos. I mean, we have links to these YouTube videos that we can do. We talk about therapy, talking to someone that can help kind of focus back that bandwidth into your daily tasks to be more efficient. Another thing that we are doing research on and we are seeing more and more research come out of is exercise. How good is exercise? How good is physical activity? If you can find yourself the motivation to exercise, And we are starting to see that daily exercising, Tai Chi, Qigong, all those things, they are very helpful in reducing the anxiety, as well as giving some of the physical focus that patients need. Next one. So when I said that the treatments are completely different for acute anxiety and chronic anxiety. So in the first month up till 3 months, what we do is we think about medications like benzodiazepines. Now, this is a big name, but you guys probably know about this: Ativan, Xanax, alprazolam, lorazepam, right? These are all the medications that we use in acute anxiety. And there's a great role for them in acute anxiety. I'll tell you that a lot of people, when they have their yearly review and they're feeling anxious, taking one of these pills can actually help you relax and focus on your work that day. But now there's a catch. The catch is that after a few weeks, up till 3 to 4 weeks, if they work great, afterwards they start losing effect. Not only do they lose effect, afterwards they start making people slightly drowsy, slightly slower, which on top of a chemo fog makes things worse. So we always ask, is this long-standing or short-acting, short-standing anxiety? Other things that you can use, the mood stabilizers like SSRIs, escitalopram, citalopram, Zoloft, sertraline, SNRIs, Cymbalta, duloxetines, all those things, right? Prozac, Paxils, they work great if you start them at the right time. In certain people who don't like to take pills and who don't want to like try any of these, a short course of antihistamines can help a little bit as well for a couple of days, if that's the case. Antipsychotics are another branch that can be used. And that's why I use the word can be used. I mean, not that we often use them. Again, the idea is that if your brain is working overtime and not letting you sleep, if something can help you sleep, these are medications that can be used as well. Next slide, please. So now the question becomes chronic. Benzodiazepines, do they have a role? In certain chronic anxieties, they have a role. If a person has certain kind of personality disorders, let's say obsessive compulsive disorder, if they have other issues that require a presence of a benzodiazepine, they can work. But primarily what we use are medications like Zoloft, Prozac, Paxil, and no, I do not have any financial association with any of them. They can be used and they're successfully used. And one of the things that has happened with these medications is they have become more refined. They have changed over time to a more refined formulation where they have lesser side effects, where they have lesser impact on your daily function. And if someone is already feeling like a foggy brain, the newer medications have lesser capability of causing that. So that's the good part. And I'm someone who's very interested in herbal medications. And some of the things that I recommend are things like kava. I mean, if your liver can allow that, a little kava can be very helpful. Lavender at night, in the evening, rubbing some lavender is very helpful. And I don't have a certain brand. I usually ask people to look around, go to Amazon or someplace and try to find out which has better reviews for the certain reason that they're using it for. A chamomile tea. I mean, I sometimes use chamomile tea at night when my kids are driving me nuts and I want to go to sleep early. That helps me calm down. That is really helpful. Lemon balm. I mean, application of that can be really helpful. Valerian root. That is something that you can buy at a GNC store or one of these herbological naturopathic stores. So these are things that you can use and they help a lot. So this is how I have worked through the process of managing anxiety in addition to medication management using some herbological. I always tell people that if you're on a trial, if you're actively getting chemotherapy, make sure that all your physicians know about it. Sometimes there are interactions with these herbological medications. So make sure that you run it by your physicians. I would say 90 to 95% of the cases, they will say yes to all of them. Next slide. So again, this is a very complicated slide, and I don't want you guys to worry too much about this. But anytime a patient comes to me, there are a couple of questions that I ask. If they say they're more anxious, I try to look at medications that work better for anxiety. If they feel more depressed, we use about that. If they feel that they have less energy, we can use medications that have slightly more activating ability. If they're feeling sedated, or if they don't want to feel sedated, we can find certain medications. Certain people have numbness in the hands and the feet. That is something that we see in patients who've had chemotherapy before, right? So we can use certain medications that can help while helping with the mood, anxiety, depression. If some people have gained weight, we can try to find certain medications which can drop some of the weight. Or if some people have lost too much weight, we can add to that. So the idea is that there are different medications. And when I have someone who says I have anxiety or I have depression, I usually go through the list of, okay, are you feeling tired? Are you able to fall asleep at night? Do you have numbness in the hands and the feet? Have you lost weight? Have you gained weight? So I ask all those questions. And the idea is to find the specific drug that hits most of these issues. So not only do I get a benefit from an anxiety or depression standpoint, but I can help with the neuropathic pain or the metabolism or weight related issues or the tiredness and all those things. Again, these things are not really super kind of like helpful with these issues, but maybe you can add a little more bang to your buck in a way. So that's how we choose medications when someone comes to us for certain symptoms. Next slide. Now, what scares the bejesus out of me, right? So if a person comes in and says, I am thinking of killing someone. Now that's a question that I asked. And some people were like, well, doc, you know me for ages. Why would you ask me if I want to kill someone? Because that is something that sometimes can happen. Some people feel like they are not too happy. I asked a straight question. I was like, do you feel like hurting yourself? And the idea is safety for yourself and someone else. So these are things that require more closer monitoring. And that's something that Rose will talk about as well. If someone has bipolar symptoms that are getting worse and they're switching quickly between those symptoms, or those symptoms are becoming too prominent, that's something that I'd like to focus more on and ask more questions on. If someone has generalized acute symptoms, if someone has prior substance abuse issues, if someone has a very bad history of sexual abuse, I mean, not very bad, any sexual abuse, or very dense symptoms of anxiety and depression that you just cannot penetrate through, then at that point, what I do is that I make a referral to a psychiatrist. A psychiatrist for a couple of reasons. Number one, basic things, palliative care, oncology, hematology, we can manage. But if it comes to a point where specialist care is required, we have some very good people around who can take care of our patients, and they already have a baseline understanding from the history we give them. So we want them to focus on certain specific things. Next one, depression. Let's talk about depression really quickly. Depression is something that I feel at times when I'm like overwhelmed with multiple things. And usually depression does not come as single-handed depression. Depression comes as a bundle with anxiety, right? So usually what I ask is that over the last 2 weeks, Mr. X or Miss X, have you feel depressed? Have you lost interest in doing things that you used to enjoy? Do you still enjoy them? If someone says yes to both of them, then I ask for a couple of other things. I ask if you've lost weight or if you've gained weight, if you feel slow, if you feel physically tired, if you feel fatigued, if you feel guilty of something, if you feel that you cannot concentrate beyond what you could not concentrate. And if there are thoughts of hurting yourself or someone else, then those are things that I kind of decipher more and try to figure out what specific medication can be given, what specific treatment can be given. So if your doctor asks these questions, don't be alarmed. This is how we think through our head, try to figure out criteria, try to figure out different symptoms and try to put them in different places. So if you ever come to me and I say, do you want to hurt yourself? This is what I'm trying to kind of decipher. It's not that you're trying to hurt yourself. All right. Next slide. Now, if someone has acute depression, acutely worsening depression, and this is something that we see in a couple of scenarios. Number one, we see them in scenarios when person has gotten a bad news and all of a sudden they are worried about something. Or if they have a loved one who's not doing so well. There are certain reasons to feel acutely depressed. Now, going back to that big blue slide that I showed you, we can use medications, right? And one of the things that I say is that, listen, if you're feeling too overwhelmed, if you feel that you're not able to take care of tasks at home, or if you're worried that you will not be able to eat or do some certain things to yourself that you don't want to, come inside to the hospital, call our helpline. We'll make sure that, there's someone who talks to you, and if need be, gets you admitted for a few days. And that can ease things off, get some medications time to work, and that can take care of things. On the other hand, if someone has chronic depression, chronic persistent depression, one of the things that I do is ask them what medications they're already on. And if they are helping, or if they ever helped before with these symptoms. Let's say if they never helped before in the first place, then the question is, should we just remove them and start something new? It is very common for someone to respond really well to a certain medication for their mood, and for someone else to not respond at all. So we try a couple of them. So what I do is, once I have someone and I change their medication, I usually have them come in 4 weeks and ask them, how are you doing now? Or I'll do a telemedicine conference with them or something to make sure that they're getting benefit. If they're not getting benefit, I'll add a second medication, or I'll take away that medication altogether and add a new medication altogether. So that's how I kind of like run through the, like, let's say if XYZ has not worked, let's try ABC. So we go through a different spectrum of medications, but the key is to closely follow up with the patient, ask them about their symptoms. And if it's not helping or they're getting side effects, remove that medication. It's going to be almost useless at that point. Next slide. Counseling, psychotherapy, exercise, all these things have shown benefit. As we are getting more outside the pharmaceutical realm of managing mood-related issues, we are starting to see that these things have a lot of value. Patients, especially in cancer-related realm, in most cases, they don't have long-standing depression to start with. It's the cancer that is playing a number with their head at that point. It's the cancer that is causing them to be worried about things. It's the worry about the cancer. It's the worry about the treatments for the cancer. It's the worry about what the financial situation would be afterwards, worry about the family. So counseling, psychotherapy, all those things help. Exercise, there's good element, there's good evidence that exercise produces certain chemicals, and that counteract the chemicals that are produced as a result of depression and worries. So I usually tell my patients, take a walk outside. It's a crappy day outside today, but on a nice sunny day in the morning, it's beautiful. If I had time, I would walk with them every day. So that's what we recommend. Exercise has a huge role in managing low mood. Next slide, please. Again, look at this. Okay, let's go into a little more depth of this. If someone says they have quote unquote depression, what options do I have? Look at the column of depression. I don't want to teach you medicine, but I'm going to send you a bill for medical school, sending you to medical school here. So depression, sertraline is one of these medications that works good for depression. Effexor, venlafaxine works well. Amitriptyline, mirtazapine helps well. Now I'll ask, okay, so Mr. X, you are feeling depressed. Are you feeling activated? Are you feeling low? And the guy says, no, I'm not. I'm feeling low energy. In that case, in the activation column, I see venlafaxine gives the best. Okay, so if that is the case, then I ask, do you also have burning in your hands, or have you gained weight? You say, oh yeah, I have gained weight and I have burning. Oh, so venlafaxine can help with those too. Great. So that's how I find out the drug that works for the mood. If someone says that, you know what, I've lost a lot of weight and they're depressed. Oh, so okay, so gained weight, lost weight. Are you able to sleep? No. Okay, in that case, amitriptyline or mirtazapine may be better choices for you. So that's how I would kind of express depression management to someone. in a way, I kind of tell my patients about this so that they know that if this drug fails, there's a backup. If that drug fails, there's a backup behind it. We have options beyond options. And this is just a small little table. There are many more drugs that are available in the market that we use in addition to this. Next slide. Again, I mean, the same symptoms are the red flags. I wouldn't even call them red flags. I would say a reason for more concern or deeper question is what I would say. Next slide. Okay, now sleep. Um, Sleep is an issue. I wish I could get more. That's always helpful, right? I used to work in New York City, and we had a colleague who was a psychiatrist, and he never had issues with sleep because he slept during the consultations. So yeah, we try not to do that. But if I were to define insomnia based on the medical definition, there are three criteria for if I say someone has insomnia. Number one, they should have difficulty falling asleep, staying asleep, or waking up earlier than they want to. That is the first criteria. And when that happens, the next step that happens is that because of the sleep disorder, people have impaired daytime functioning. They cannot function. They cannot do all the tasks that they want to. So that is the second thing. And the third thing that I ask for is that how often does that happen? Some people have, oh, maybe once a month. Well, that's not insomnia, right? If it happens more than 3 times per week in a specific month, then that is insomnia. It's a persistent issue. It's a chronic issue. Then that is insomnia. So if you cannot sleep, if you cannot keep asleep, and you wake up early, and then you cannot work in the daytime, and it's happening very often, more than 3 times a week for more than a month, then you have insomnia per definition. Next slide. So again, everything is an acute and a chronic. Why? Because treatments are different. If someone has acute insomnia, that is less than 3 months. If someone has chronic insomnia, that is persistent more than 3 months. Insomnia can happen with a lot of things. Insomnia can happen because of medical disorders. I mean, I can tell you that a lot of my male patients who come to me and I ask them about insomnia, the first thing that I ask them is like, how many times do you have to wake up to pee at night? And a lot of them say, well, I have to wake 3 or 4 times. I mean, that can mess anyone's sleep, right? So insomnia because of a medical issue. Some people wake up because they're on certain medications where they get thirsty. And they wake up and they are so thirsty, they wake up and they have to drink water and then they cannot fall asleep. That's another thing that happens, right? So we always ask about medical disorders. Sometimes they're on steroids that their doctor is giving them as a part of their chemotherapy.
Outside.
They cannot sleep. So that is another thing that can happen. Sometimes they have other psychiatric issues that can make them not sleep. So we ask about that issue as well. If someone is anxious all the time, they cannot sleep, that's a problem, right? Or there is another form of sleep on which a lot of sleep specialists are making a lot of money, and that is insomnia with another primary sleep disorder. So what that means is that some people have obstructive sleep apnea. Sometimes they snore a lot at night. They cannot get enough oxygen. So you have to go to a sleep specialist who can manage this. So there are different kinds of insomnia, like I said. Next slide, please. Good. So people are often like, why do we have to manage this? Sure, I cannot sleep, but why is this such a big deal, right? It's a big deal for a lot of patients. It's a big deal because when you don't get enough sleep, you cannot pay enough attention or concentrate on a task at hand. You cannot remember things, right? You deal with anxiety and depression because you cannot function. You have a poor quality of life because you cannot function and have anxiety and depression in the first place. And what we have seen is that people who cannot sleep, people who have had a history of insomnia, have a higher risk of substance use, have a higher risk of self-harm. I mean, there's a lot of study and research that is being done on the immune dysfunction. People who don't sleep fall sick more often. There was a study done on the number of times a person gets pneumonia during their lifetime and its relationship with insomnia. People who cannot sleep, they had more infections because they had immune dysfunction, right? People who cannot sleep, they get anxious, their blood pressure rises, they have heart disease, they get more diabetes. So brain has a function in all this, and sleep is a vital part of that function. So this is why when someone has anxiety with sleep issues, I like to manage that at the spot and not wait for it. Because if you wait for it, it gets worse and leads to other illnesses in the future. Next slide. So whenever someone says I cannot sleep, I get a detailed sleep history. I ask, okay, so when do you go to sleep? Who do you go to sleep with? What kind of bed do you go to sleep on? How much light do you have in that bed? How much water do you drink before you sleep? How much do you eat before you sleep? How many times do you have to wake up before you have to wake up? So I ask so many questions about sleep. People are like, what's wrong with you? Why are you asking so many questions? Because we want to know exactly what is the underlying cause that's aggravating the sleep issue. I screen for anxiety and depression. I'll ask the same questions about anxiety and depression. So don't get alarmed if a doctor asks about this. This is part of the screening. I mean, I asked for another question. I usually ask, like, I mean, do you have a history of cancer? Do you have pain? Anything new that is bothering you? I mean, is there any other part of the body that you're hurting, that is waking you up? So that is a red flag again. Like, is the cancer coming back? You have to know about that. One of the things that I do is I give my patients a sleep diary. It's a little printout that we give our patients, and we ask them, and that way they can kind of write down what time they went to sleep, what time did they wake up, how many times did they wake up in between. And if you have a smartwatch, if you have one of those Fitbits, again, I have no financial concerns with any of them. Or if you have an Apple Watch, and if you wear it to bed, it can tell you how many hours did you get good sleep, how many hours did you get bad sleep, how many hours, how many times did you wake up. So it can give you data. You can actually print it out these days. This is pretty cool. So those like watches which are on Amazon sale these days with Amazon Prime Day, think about it. It's not a bad investment for people who have sleep issues. Or you can make a sleep diary on a paper. The idea is that we want to know when you fell asleep, when you woke up, how many times did you wake up in between? Did you feel refreshed after waking up? Were you able to do things in the daytime after waking up the next day? So these are the questions that we ask for in the sleep diary. Next slide. So sometimes goals are very important when you talk about sleep. I mean, you can make someone sleep 12 hours by giving them medications. But the question is that going to qualitatively and quantitatively improve sleep and then subsequently improve the quality of life? Would it improve the daytime functioning, right? A lot of patients come to me, there's something called as sleep regression as we grow older with time. We see this more often in the late 60s, early 70s, and 70s and 80s. Uh, I'll give you an example. When kids are born, children, they sleep all day long. They sleep like 18 to 20 hours, right? When they get 1 years of age, they sleep like 16 hours, 15 hours. When they become 4 years, I mean, they sleep like 10 hours or something. And then they start going to school, they sleep about 8 hours, 9 hours, somewhere around that. And when we start working, we sleep 7 hours on a good day. There's this thing called a sleep regression. I remember my grandma used to be up like at 4 in the morning, and we're like, Grandma, you used to sleep at like 11 o'clock and you wake up at 4. She's like, of course. I mean, that's enough sleep for me. So the question is that if someone can work on that level of sleep and their daytime functioning is not impaired, that is okay. It is okay to sleep 5 hours if you can function in the day. But if you cannot function, then we need to fix that issue, right? So that is important. Next slide. First step is behavioral intervention. Again, going back, before you start a medication, you try to improve things without a medication, because once you start a medication, then you're going to deal with its side effect, and maybe it won't work too long. So we start with behavioral interventions. There are a couple of things that I tell my patients that are part of sleep hygiene. Number one, go to sleep only when you're sleepy. If you're not sleepy, do not go to bed. If your mattress is bothering you, if there's too much light in the room, or if there's too much noise in the room, fix those issues. Because if they're bothering you, that's a problem. If your significant other snores a lot, I mean, change the room or try to fix their snore. Otherwise, you won't be happy. Do not use any screens in the room, in the bed, sorry. The idea is that these iPhones, right, these things that shine in your face, I mean, even though they have the night modes and like the low light modes and everything, they get your brain all activated. You cannot sleep. So no screens, no televisions, no smart watches, no reading. Some people, I mean, we have this thing where people read in bed, then they fall asleep. Apparently, if you read before bed, that can activate your brain if you're reading a thriller, right? Or something else. So what I usually say is that when you're going to bed, just go to bed. There's nothing else to do, right? If you wake up multiple times at night to pee, after 7 p.m. at night, stop drinking water or reduce significantly the amount of water that you drink, because then you'll have to pee at night, right? If someone is drinking a lot of alcohol, if you are taking certain medications that wake you up, try to try to change their time. A lot of people say, well, you know what, I drink a glass of wine to sleep. Yes, that is okay if you drink a glass of wine to sleep. Just make sure that that glass of wine does not have enough fluid in it that wakes you up at night to pee, right? So that is important. One of the other things that I do is sleep restriction therapy, which is that if you are not able to sleep at night, make sure you're not taking little cat naps during the day. Make sure that you are tiring yourself enough during the day that you fall asleep as soon as you go to bed. So no cat naps during the day, no daytime snoozing and all those things, right? Another thing that we can do is we can talk about sleep therapy. We kind of like to try to decipher exactly what are the issues and help people kind of work through those issues and improve their sleep hygiene at night. Next slide. So again, sleep hygiene, lie down only to sleep when you're feeling sleepy, avoid wakeful activities, watching television, talking on the phone, maintain a constant sleep wake cycle. If you are feeling that you are not sleeping because you're waking up at 8 or 9 in the morning instead of 6:30 that you're used to, set up an alarm. Wake up at 6:30. Uh, Water intake, like I said prior to sleep, don't drink a lot of water if you're waking up because of pain. Next slide. Again, I'll quickly go through this. Benzodiazepines, the Ativans and the Xanaxes and the lorazepams and all those things. They, you should use them very less. I mean, 20 years ago, if you were to ask a doctor, they would say, oh, of course, you can use as many as you want, but just go to sleep, they will work. Turns out that there's a thing that after 3 weeks, they start causing what we call as this phenomena, tachyphylaxis. What that means is that instead of helping you sleep, this is just another tic tac that you take or an M&M that you take in a day, and it doesn't work. And especially if you have chronic insomnia, these things are almost useless in most cases. These are things that just make you be sedated in the daytime and feel more tired and foggy. So usually I don't recommend this for chronic insomnia. And there are other issues, daytime sedation, they make you have low concentration, there's cognitive impairment, there's an issue with misuse on top of that. If you stop them, then you have withdrawal related issues for a long time. And for my older patients, it's a big issue, especially who've had chemotherapy, their bones are already thinned out. If they fall because of sedation, that's another issue. Then you're dealing with a broken bone. So what I say is that if you're not on it, do not start it. And if you're using it, use it for the minimum time that you can. Don't use it regularly. Next slide. So now there are the Z drugs, right? The Zolaplam, the Zolpidem, the Ambiens, and all those Zopiclons and all those things. They almost work the same way. I mean, the idea was that maybe we can develop these drugs and we can overcome some of the disadvantages of the Ativans and the lorazepams and the Xanaxes. Turns out they have the same issues. So after a little while, they stop working for sleep and they start causing more side effects. So they're not the best either. For short term, sure. For long term, no. Next slide. Herbal treatments, again, going back to the same treatments that work for anxiety and slow down your brain. Kava, lavender, chamomile, lemon balm, valerian roots. They're great. They help a lot with calming your brain down, calming yourself down before you go to sleep. Another thing that is over the counter these days is melatonin. These are available at any store, Target, CVS, I mean, even general stores like Stop and Shop. The trick is to start them to control your sleep cycle to get where you want to get and then stop. do not take them for long term. The doses that I recommend are between 1 milligram to 3 milligrams. These doses can work to get your sleep cycle in place. But again, the idea is to once that you get your sleep cycle in place, take away these medications. Go to sleep by yourself without taking these medications. So they can work pretty well. Okay. So this was my complete spiel. So let's go to the next slide, please. So I'll start with the questions that were already asked by different people. So thank you so much for listening calmly to me and not yelling at me. The first thing is, the first question that I got was on the email that we don't have here, but the question was, can Chemo Brain persist after 4 years of getting help? And the answer is, in certain patients, yes. Now we are getting more research done, and we're finding out that we can actually have patients, their chemo fog that can stick around for longer. Again, it can be an age-related thing. It can be a medication-related thing. It can be a long-term issue with the medications that you're still taking, but that it can persist. And it is almost treated in the same way. You try to figure out exactly what is chemo fog, which components are the most bothersome, and focus on each of them. If it's insomnia, focus on that. If it's fatigue, focus on that. If it's not being able to focus on that part. So we kind of like take away all these components and focus on each of them with certain different treatments and therapies and medications, and people feel better. So that was the first question. I hope that answers the question. Okay, so first question sent by Ellen at 4:03 p.m. I'm a patient who experienced significant effects of Chemo Brain. I work in a cognitively challenging position and was not prepared for the challenges I encountered when I returned to work. Do you feel it's appropriate to share my difficulties with my department head? Very good question. The answer is yes. So here's how I look at this. I'm not a lawyer. I will be a lawyer in 9 months, but not now. So the answer is yes, you should, for a couple of reasons. Number one, when people are not able to work in a cognitively challenging positions and they are not able to function and their boss is getting on their case, I always tell people, you know what, talk to them. There are resources available and HR would definitely help. If you work for a corporation, they have ways to kind of accommodate you. Ask for accommodations. Because if you don't ask for accommodations and your boss kind of starts giving you a tough time, that is even worse. Then they destroy your future bonuses. Then they destroy the future benefits that you're going to get and hours and all those things. Ellen, your question is very correct. We're all working. And kudos to you that you still work and you stay active and make sure that you are still a very active part of the society. So talk to the boss. Definitely they can accommodate you instead of them affecting your bonus, your performance, and all those things. And if they don't accommodate, then they can deal with certain issues for not accommodating someone's very kosher needs. All right. So yes, the answer is yes, you should bring this up. All right. Sometimes they can reassign duties. Sometimes they can decrease duties. And every boss can change the hours if you cannot wake up early. They can say, listen, why don't you do this on certain days, on half days, on a certain days, and a couple of, maybe on a half a weekend, you can come and work. If that allows, why not? Right? So try to figure out what strategy works best for you, present it to your boss, and negotiate. All right? Excellent question. I really like this question. I think this was probably one of the best questions I've had in a month.
Thank you.
Second question. Irene, is there something that works for hair thinning rather than obtaining a wig? I'll show you my head, okay? This is real honest stuff. Look, you see this? This big hole in the back? Yes, I'm losing here. And here's what I used. Again, I have no financial relationships with any of them. Let me see. Let me show you my thing. And it has worked well for me, actually. I started taking this Biotin supplement from Amazon. Hair, nails, and skin, right? Now my nails grow really fast and I have to trim them every like 5 days. That's fine, right? But I used to have a lot of acne. That's gone. That's something that I use myself. And that has definitely helped with the quality of hair, the hair shine, and the thickening of hair. That's one of the ideas. The other thing is that another thing is that eat healthy, eat vitamins, make sure that your diet has a lot of vitamins, multivitamins, and all those things, they help. Third thing is medically, yes, we can give finasteride and all those things. I've never used it, but I mean, people live by them and say that they really help. Another thing that you can get from Costco are things like Minoxidil, Minoxin, and all those things, or what's that called? Rogaine, Rogaine. They apparently work. You have to use them regularly, and if you stop them, the hair loss starts again. But again, within 4 to 6 weeks, people start seeing effects, and I know a lot of my friends who've had benefits from there. These are the three options that I have. And as far as obtaining a wig is concerned, wigs are awesome. I mean, I watch that late night shows on TV. Everyone, like the Real Housewives of XYZ City and Atlanta and New Jersey, everyone wears them. Wigs are the new, new in thing. I mean, yeah, it's not a big thing. The next question is our eyebrow microblading an option with leukemia? What is eyebrow microblading? Tell me.
It's a tattooing of the eyebrow,
Ooh, yes.
micro
Definitely.
tattooing.
If you lost your eyebrows and the eyebrows are not coming back to your liking, you can ask your oncologist, and there's a very good chance they'll be okay with it. Not in the acute phase when you are going through acute therapies for leukemia, but in later stages when the disease is well controlled, I think that should be okay. The idea is that you should get it from some place where risk of infection is low. Make sure that you talk to your oncologist, because there are a couple of things that can happen. Number one is infection that we talked about. Go get it at a clean place. Make sure your white count is fine. Your white blood cells are in good place. The second thing is bleeding. If your platelets are low, that can cause excessive bleeding. And if you're on certain medications, that can increase bleeding. So ask your oncologist if you're on certain medications that can increase the risk of bleeding, so that when your tattoo artist is working, not tattoo artist, sorry, microblading specialist is working on them, that they know that this can happen, and they use needles which don't cause as much trauma, right? So definitely an option at the correct time. I think it's a great idea. It's a wonderful idea, and we should actually be talking about this for our patients who've lost their eyebrows. Definitely. Okay, next question. Has anyone done a before chemo and after study to evaluate the effect of cancer chemo on listening processes and vision changes? Yes. Yes, there are studies on this. Yes, great question, Ellen. You ask amazing questions. Okay, so there are certain chemos that can affect your hearing and affect your vision. Now, it can happen as a primary process, or it can happen because it affects the brain, or if it affects the nerves that go to the part of the brain where you kind of like use that part of the brain. So just so you know, vision is controlled by the part of the brain right in the back, right at the very posterior brain, like where you get slapped by your mom when you do something wrong, right? I got slapped a lot, so my vision is back. So, but the point is that a lot of things can affect the vision. Definitely, if your vision is getting worse, I recommend that you go and see an ophthalmologist, an eye doctor, try to figure out what the underlying reason is. If your vision...
Can I interrupt? The ophthalmologist had no clue. I had to go to a neuro-ophthalmologist to
Yes,
get prisms in my lenses and those things.
definitely. Ellen, if that is something, the answer is yes. There are certain, we call them autotoxic chemotherapies, they can cause it. And especially with certain people, when they get infections while on chemotherapy and they get certain antibiotics, they can make illness hearing even worse. So the answer is yes, there have been studies done on it with certain chemotherapies, and it can do that. It can do that. And with a chemo fog, the effects of vision focusing can even become worse. So, because we as humans, I wish we were bats, we had better hearing. That would be so cool. But I don't know why I said that. But we use all five senses when we focus on something. It's the touch, it's the feel, it's the hearing, it's the vision, it's the tasting, not the tasting, hopefully, unless you're a chef. But we use a decent amount of our senses. And if our brain is cloudy, we cannot use those efficiently. Even if the eye is fine, the processing unit is not fine. So that's a problem. So that's how it works out. So yes. Can the speaker speak a little louder? I did. Thank you. Okay. Next one. Are chemo brain symptoms are permanent or temporary? In most cases, they're temporary. They get better once the chemo stops, but some remnant can stick back. And that's something that we talked about in question number 1, which was, after 4 years, can I still have that? And the answer is yes. Unfortunately, that can stick around. And if they do, I mean, dietary improvements, if nothing else has worked and all the workup is negative, everything looks good, then you start working on exercise, focus on each and small little factor of chemo brain, and basically then try to focus on that. Maybe we can tweak things up a little bit, but sometimes these things can unfortunately stick around too long. So, yeah. Okay, what kind of doctor is Dr. Habib? I don't know. Okay, so I'm primarily an anesthesia and pain physician. And I'm also boarded in, I have 5 different specialties, and one of them is anesthesia, one of them is pain, one of them is palliative care, one of them is internal medicine, one of them is addiction, one of them is integrative and herbal and acupuncture medicine and all that. So some of these things. So when patients come to me, I put all of these hats together and I join them to kind of find the most non-invasive form. So that's my thing. I'm not smart enough to be an oncologist. We have enough of them at CINJ. Am I a neurologist? No. I wanted to be one. They didn't take me in a residency. Psychologist? Hell no. All right. Next one. Interesting point. I thought I was the only person who can gain weight. That is true. A lot of people gain weight. Yes, you can gain weight after chemotherapy. A lot of people, what happens is that they improve their diet, they improve their things, they gain weight. The other things that happen is that they don't have the energy levels to exercise and find focus in their day to work out and all those things, and they gain weight. So yes, that can happen. All right. So that is something that can be seen. So exercise, careful eating, all those things can help. Okay. And next question, I've tried various antidepressants prescribed and don't feel that they have a noticeable effect. What do you recommend? I think we talked about this a little bit, that if certain antidepressants don't work, then you try to figure out which one works the best. Sometimes they don't work completely. They just cover one aspect of your depression. At that point, what I say is that start doing some behavioral therapy. That can help a little bit. Talking to someone, that can help. In addition, what I recommend is exercising. I mean, I'm focusing on exercise, and I know I'm talking about it for the 5th time right now. What we found out that exercise, again, like I said, can produce certain chemicals that can counteract the effects of certain chemicals that are produced with cancer-related depression and chemo-related chemo fog. So that can really work. Sometimes change in your lifestyle, that can happen, that can help a lot. If you're working in a place where things are awful, try to find a job that is not as awful. I mean, I can tell you, my family drives me nuts. If someone is driving you nuts, try to avoid that person. Take out the negativities in the life. That can add a lot of value. Again, that's not a doctorly advice, but negativity affects our brains, and that's not good.
Dr. Habib, can I break in just a second?
Yes.
Okay, so I do know that some psychiatrists are doing some genetic testing. to find out whether or not, which medications may work best for you, which may not. And there are specific genetic, testing that can be done for psychiatric meds. And it may be that it's not necessarily the med, but maybe the dose. But I just happen to know that, so I thought I'd share it.
No, definitely. And by the way, this is Rose. She is amazing. And I've taken away 15 of her minutes, and she should interrupt me every second and show me like the most angry faces. All right. So last question. When having chronic anxiety, having used to deal with it without treatment, does that go better or worse through time and without medication? So there are patients who have had medications for anxiety and they've done well. And there have been times when these medications stopped working. At that point, either you change the medication or you add to the medication. Let's say someone is not taking any medication. If taking a medication in the daytime improves the quality of life, improves your function at work, at home, improves your interpersonal relationships at all these levels, and it doesn't cause side effects that prohibit you, I think taking a medication is the right thing. Does it get worse or better? Medication treatment does not determine it. But we know that if someone's medication is working and they stop it, their depression rebounds, and that can be difficult to control. So I hope that answers the question. It's a very complicated question, but the answer is that if you are dealing with chronic anxiety and you're not on a medication, maybe if medication improves your quality of life, it's not a bad trial if side effects are not limited. Thank you so much for your kind words, Ellen. And definitely, if this is recorded, I'm more than happy to provide. Acupuncture for peripheral neuropathy? No. I do acupuncture and I'll say no. And Rose, I'm sorry I'm taking this time. The answer is when you have peripheral neuropathy, if they do acupuncture on the earlobe to kind of make you feel better, great. But if there's a peripheral neuropathy in which local treatments are being given in the area where you have numbness, that can be a problem. And the reason why I say that is because you've probably all seen diabetic foot. It starts with a little wound or a little pinprick kind of an issue, and it gets bigger. So if you're getting acupuncture in other parts of the body where you don't have numbness and you're feeling better from it, continue. I'm all for it. Acupressure, Tai Chi, Reiki, all those things, healing touch, all those things, I'm completely on board with that. But if your acupuncturist is inserting the areas where you have peripheral neuropathy, yeah, I mean, medically, that's not the smartest thing. So I would say no to it. Oh man, more questions. Attempted Lessapro with improvement of mood, however, impotency, 30-year-old male. Very true. That is true. Impotency is a huge issue with these medications. And this can be reversed with things like Viagra and other things, 30-year-old male. Yeah, it can be improved with those medications and testosterone supplements and all those things. So it can be reversed. Do you have a private practice? No, I don't have a private practice. I've worked with Rose and she's awesome. And I cannot imagine working without her. I am a university professor on faculty at Rutgers and CINJ and RWJ, and I'm very happy here. Private practice is not good. We work for the community, we don't work for money.
That's a great segue to introduce Rose.
Exactly. Rose, I owe you 22 minutes. Okay, next time.
No worries. No worries.
In good hands, guys. Thanks for all the questions and thanks for the good, kind words. Take care.
Thank you, Dr. Habib. Alicia, do you mind just using the slide deck you have, and I'll have you change the slides if that's all right?
Oh, okay, hold on.
I'm so sorry. I could have sent you a private message and asked that, but I didn't. Everybody, this is a great moment to take to go to the restroom if you have to, or get up and stretch your legs if you need to. Please take that time. Also, please remember to mute yourself if you aren't already muted. And thank you, Alicia. I really appreciate it. So we'll just wait for just a couple of minutes to give people an opportunity to to get back from the bathroom or doing whatever it is that they need to do, because sometimes, an hour is a long time. So I'm just going to say a little bit about myself while we wait for people to come back, if that's okay. So my name is Rose Slizeski, and I use pronouns she, her, and hers. And I'm a licensed clinical social worker here at Rutgers Cancer Institute. I have been here since I've worked here since August of 2006. And I work with various tumor study groups and have worked with very, diverse types of cancer patients over the years. I'm also the facilitator of the Living with Cancer support group. And that's a support group that happens twice a month on Wednesdays. It's the second and fourth Wednesday of the month. My email is on this slide. And so if you would like to have more information on the Living with Cancer support group, please don't hesitate to reach out to me. So I don't know if we've lost people permanently or if we've lost people temporarily. I did say it was okay to go to the bathroom, but I do think because I have a little bit reduced time that I will start. Next slide, please. So a lot of what has been shared by Dr. Habib has been pretty thorough. And so some of this presentation is going to be a little bit redundant because he's really thoroughly, provided the medical information, but I want to hopefully share some of the information that I have, focusing more on psychosocial issues, and I hope to provide some helpful suggestions that assist people who are dealing with chemo brain, insomnia, anxiety, and depression. So first, chemo brain, and we've looked at the medical aspects, and so now let's look a little bit further. Next slide, please. All right, so mental changes that may be experienced as a result of having chemo brain cause an individual to forget things, including names, important events, dates. This is clear that there's an impact on concentration and focus, and then that in turn impacts day-to-day performance, whether that's at a job, at work, or just in your daily activities. They make it easy to lose track of what it is that you're doing, right? More unable to do more than one thing at the same time. I've avoided using the term multitasking there because I actually think that it's a misnomer. There really isn't anything like multitasking because we really can only truly give our focus to one thing at a time. And chemo brain can create difficulty learning new things or finishing tasks. So these are just a few, and I know that Dr. Habib also reviewed some some mental changes that can be experienced. Next slide, please. So impact on the patient and those who love them. So if you're the patient, frustration, feelings of being overwhelmed, having overwhelming feelings, worry, isolation. So the frustration, well, this is pretty obvious. I think that if you are having a difficult time forgetting things, forgetting names, forgetting important events, this will be frustrating and sometimes embarrassing for people. Overwhelming feelings, those can include, embarrassment, but also can include anger and frustration, guilt, fear, stress, a loss of self. I had a patient once say to me, I couldn't find Mary anymore, and I'll just call her Mary. That wasn't actually her name, but I couldn't find Mary anymore. So I'm happy to report that that resolved for her, but that feeling of sort of just not being yourself was certainly incredibly distressing. Now, worry too is a very understandable thing. If you are a cancer patient and you are experiencing mental changes, the concern can certainly be, is this dementia? Is this early onset of Alzheimer's? Is this brain metastases? We tend to think about the worst, but it is understandable why somebody would worry. And then isolation too. Sometimes people, when they're feeling like they're not themselves and can't predict when they'll forget something, they may tend to stay away from certain interactions, being afraid that they might either embarrass themselves or someone else, and they may not want other people to be concerned about them. So they don't want someone else to see their symptoms. And they may also not want to answer questions about what's going on with them. So isolation is something that can happen. But it also, this Chemo Brain has an impact on caregivers and family members and friends, right? Because first and foremost, they're going to be concerned for the people that they love, right? So that concern can sometimes create a disconnection because the person is not who their loved one or family member or friend remembers them as, so there can be sort of a loss of connection and concern, of course, but a loss of connection as well. There can also be a feeling of helplessness because they don't know how to be of assistance, and that can cause a disconnection to communication issues may be a challenge, and they may feel, loved ones may feel that they don't necessarily know how to ask the right questions of the person who's suffering from Chemo Brain, may not feel like they can ask the doctor questions about that, and so communication issues can arise, and also just misunderstanding, and there can be some gatekeeping. Usually there's no malicious intent here, but if you have a loved one who is dealing with Chemo Brain, it may be the case that out of a desire to really protect them, family members and friends and caregivers may act as gatekeepers, and that is to sort of means try to manage the person's interactions with others, and maybe even limit who sees them because they don't want, they're trying to protect them. Next slide, please. So those were some of the impacts, but so what helps? Well, open communication with both the medical team and between the patient and caregivers. So if you're the patient, it's so terribly important to inform yourself about what Chemo Brain is and what it's not. Get the facts, which is what you're doing today, right? So give yourself a pat on the back for being present here and signing up for this presentation. I'll be repetitive, just like Dr. Habib was. Regular exercise, and that can just mean a walk around the park. It can mean a walk around the block. It can mean a walk around the house. But getting some regular exercise, getting adequate recuperative sleep, that is sleep that makes you feel refreshed and renewed when you get up, right? Appropriate eating habits. All of us have some inappropriate eating habits, but again, appropriate eating habits can assist you when it comes to dealing with Chemo Brain. Participating in positive stress reducing activities. It's really hard to stress how important it is not to just isolate, but be engaged in things that are fun and things that maybe can reduce your stress a bit, things that you found enjoyable in the past, right? Please do realize that it's important to be gentle with yourself. It's important to remember that this is a new experience you're dealing with, and you may make some mistakes in dealing with your Chemo Brain. Well, mistakes are part of the human experience. There's really no way around that. Tell people what's going on with you. Tell your medical team what's going on with you. Tell the people that you love and care about what's going on with you. Be open and honest to the best of your ability, and at the same time telling them what helps and what doesn't help. Because people who care about you, if you're the patient, are going to want to help, but they may make assumptions about what it is that's going to be the most helpful. And those assumptions may not be as supportive. So it's up to you to communicate clearly and openly with your medical team and your caregivers and your friends about what's going on with you and what's happening, right? And so when we talk about participating in these stress reducing activities, we're really talking about things that help reinforce neuroplasticity, right? Cognitive rehab may be an option for you. And the only way you're going to know that is if you're open and honest with your medical team and letting them know everything that's going on with you. And they can tell you whether or not they think it's appropriate for you to go and explore cognitive rehabilitation. That too is the kind of rehabilitation that people who have frequent concussions and things go through. And the cognitive rehabilitation, what it does is it helps to address the symptoms by including some activities to improve brain functioning, by doing some repetitive activities, doing some activities repetitively, and helping you learn tools that can help you navigate the chemo brain. Sometimes what we're doing is trying to do some adaptation and some behavior modification to make the chemo brain a little bit more manageable, right? So mindfulness and meditation. Very few of us are able to just sort of sit down and shut our mind off. And that's not the point of meditation. Really, the point is looking at ways to help focus, allow yourself to have to have a thought. If you're sitting and meditating, you may have a thought. And it's not being mad at yourself for having that thought, but not following that thought, just letting it come and letting it go, right? Not grabbing hold of the thought, not focusing on the thought, right? And meditation and mindfulness can really assist in doing things, helping you just be grounded, helping you be in the moment, helping you be present right now. And you may find that that is actually really helpful. And there are apps that, Dr. Habib talked about some apps, and one of them is Insight Timer, where you can go and get a 3-minute or a 5-minute guided meditation that somebody is sort of walking you through. And again, meditation and mindfulness, they require practice. They aren't the kind of things that will one and done. It's kind of like going to the gym and working out once and wondering why you didn't lose weight. So it's a practice. Mindfulness is a practice, and it will be helpful if you follow through with it. And exercise your brain. Try something new. Exercise your brain by playing chess, playing rummy cube, brain puzzles, or jigsaw puzzles, or word puzzles, things that engage your brain. And if you are doing something new pathways develop in your brain. And that is, and that's something that is, I talked a little bit, I just mentioned the word neuroplasticity before, but we're trying to help the brain deal with what is happening. And so trying new things can really be very helpful. Next slide, please. Now, as far as tips for caregivers and family members and friends, right? A respectful, open communication. Again, the communication is key. Ask somebody what it is that's going to be helpful. Ask your friend, ask the person who's suffering, what can you do to be helpful, and do not assume and sort of take over what you think will be helpful. Do what you're doing today. Get the facts, understand what Chemo Brain is and what it's not. And again, applaud yourself as well for being here today. Have patience with your loved one and with yourself. This is a new experience, and it will be somewhat challenging. And but you're getting further information. But have patience with yourself. This is not, you're not going to just know everything you need to know and know exactly how to be the most supportive, person that you can be around this by, one presentation. Right? Flexibility and understanding. If your loved one, if the patient is dealing with chemo brain, it's really important to be able to be flexible around roles, be flexible around those things that, flexible around expectations, because if people aren't functioning the way that they're used to functioning, then that means that, it may be the case that balancing the checkbook is going to have to fall to somebody else, for a little while, and some other things too. So that's, flexibility is going to be really helpful. I can't stress this next one enough. Take good care of yourself. You know, sort of like the safety instructions on the airline, right? You put the oxygen on yourself first, and then you help someone else, because you can't help anybody if you're passed out, right? So taking good care of yourself, making sure that those things that recharge your batteries become a priority for you, so that you can, you know, be supportive to the person, you know, your loved one, your family member, your friend who is dealing with Chemo Brain, right? Focus on the positive, find an element, one element, whatever it is that day, that, you know, we can focus on the positive. Focusing on the positive actually does help in coping, right? And whatever those efforts that the patient has engaged in to combat Chemo Brain, participate with them. You know, be an active participant in those same activities, and it'll help you and it will help them. Next slide, please. Okay, so that was Chemo Brain. Now we're going to talk some about insomnia, right? Trouble falling asleep, staying asleep, or poor quality of sleep. Sleep resulting in not feeling rested or refreshed afterward. All of us have trouble sleeping sometimes, but insomnia is something different. And I know that Dr. Habib gave the actual medical criteria for diagnosing certain types of insomnia. So next slide, please. All right, these are just some statistics. It's for short sleep duration. And the one on the left gives a breakdown of, you know, by age, by race, by gender. And really, it just shows that there is a high percentage, you know, of people, somewhere between 25 and 46 or 47% of Americans deal with not getting at least 7 hours of sleep, right? And the graphic on the right shows that where you live can really seriously impact that too. So the darker the green, the higher the incidence of short sleep. Next slide, please. So different types of insomnia, and I know that Dr. Habib again discussed this as well, but sleep onset insomnia, right? So having difficulty getting to sleep, falling asleep, having difficulty feeling relaxed in bed, having difficulty shutting your mind off. That is something that I hear patients say quite a bit, that shutting their mind off is one of the things that is the hardest thing for them. And it makes it difficult for them to fall asleep. Sleep maintenance insomnia is exactly, you know, kind of what it sounds like, right? It's having difficulty staying asleep after initially falling asleep. And this is common with sometimes common among those people who are somewhat older, and with the consumption of certain things, caffeine, alcohol, nicotine, even sugar prior to going to bed. You know, these can impact whether or not you have to wake up. So it may be a result too of getting up without wanting to stay, you know, you wanted to stay asleep, but you're waking up, and that can be a result of disorders like sleep apnea, like restless legs syndrome, like having bladder issues. And so then too, there is something called mixed insomnia, right? Having both sleep onset and sleep maintenance difficulties. And I know that these were addressed to some extent, but again, the most important thing is to make sure that you get assistance if it's really, if you find that you are experiencing long-term chronic insomnia. This can have really significant long-term negative effects, and it's incredibly important that you seek help for that. Okay, next slide, please. Okay, so the causes. Basically, hyperarousal is a cause of insomnia, lots of different kinds, right? And so either you're aroused, hyperaroused mentally or physically, or both, or a little bit of both, or a different combination of both, right? Poor sleep hygiene, such as going to sleep at varied times and not sticking to a sleep pattern, too much screen time before bed, shift work, too much noise or light in sleeping quarters, and daytime sleeping, right? So I can say, this is where I would like to say, take my advice. I'm not using it. I I have some trouble sometimes with insomnia, and when I do, usually it's sleep hygiene. That's the problem, right? Not sticking to a sleep schedule, or there being too much noise or light in in my bedroom, or it's not so much daytime sleeping. I don't think that I'm doing too much napping, but anyway. So that can be the environmental causes, right? Psychological causes. So having pre-existing or co-occurring depression, anxiety, stress, excessive worrying about sleeplessness can actually keep a cycle of insomnia happening. So it can be a vicious cycle if there's a lot of excessive worrying about not being able to get to sleep or stay asleep, right? And then physiological. So consuming alcohol, nicotine, caffeine, and other drugs, including cold remedies, including things that are over the counter that you think are probably fine, but they can create some hyperarousal and thus either keep you up or wake you up, right? Exercising too close to bedtime. Well, here you may think that you're tiring yourself out, but exercise, depending on the type of exercise, if you do it right before bed, can be actually pretty arousing. And we're not talking about sex here. But exercise close to bed is actually not good as far as sleep hygiene goes, right? And adjusting to new prescription medications. So there may be that there are medications that you have to take. And until your body adjusts to those, you may have a reaction that makes your sleeping more difficult. And so again, just be mindful of that, right? Also physiologically, sleep apnea, chronic pain, chronic restless leg or bladder issues, chronic illness such as cancer, heart disease, reflux disease, asthma. These types of illnesses can create sort of illness-induced insomnia. And so, for our purposes, I think it's important to just look at some things that can be helpful regarding insomnia. Next slide, please. Okay, so some obvious symptoms and some not so obvious ones, right? Some insomnia symptoms, difficulty falling or staying asleep, right? Early waking, not feeling tired at bedtime, fatigue and generalized malaise, memory and concentration problems, poor work performance, poor school performance, irritability and mood disturbances. When we don't get enough sleep, we can be really grouchy, right? Behavioral problems like aggression and hyperactivity. These are some, some obvious and not so obvious symptoms of insomnia. Okay, next slide, please. So dealing with insomnia, again, the primary suggestion for helping deal with insomnia is to develop a pattern of good sleep hygiene, right? Some people find that setting time aside about 30 minutes or even a little bit more before bedtime, of dimming the lights, of things getting quiet, of not engaging in things that are that will get your heart going, that will get some body chemistry going, that's gonna be counterintuitive to sleep. Again, if you're gonna read before bed, not a thriller, right? So some primary suggestions, again, is that good sleep hygiene, eliminating naps or really limiting them to the extent that you can, restricting intake of caffeine, alcohol, nicotine, sugar, especially late at night, avoiding late meals and snacks. Digestion, can make it difficult to fall asleep, curtailing screen time prior to bed. And I know that this was discussed already, but that does sort of trick your eyes and your brain into thinking that it's okay to be fully awake, and so we want to try as much as possible to reduce those things that are stimulating prior to bed, right? Maintaining a healthy diet and exercise routine. Again, this keeps coming up, but it's important and valuable. Follow a steady schedule for sleep, including regular bedtime and wake up times. Next slide, please. So additional tips for insomnia relief, obviously, seek professional help and psychological assistance if you need to do that, and talk to your medical providers about sleep problems and symptoms. Ask questions about the illnesses that you have and the medications that you take for them. Ask if they can be contributing to your insomnia, right? Ask about potential impacts of these things on your sleep, and maybe even some over-the-counter medications that you're taking. And ask if a sleep study is right for you. It may be, it may not be. But again, open communication with your medical professional staff, your medical professionals will help with that. Pursue therapeutic assistance from a mental health professional. That means a psychologist, a licensed clinical social worker, a licensed clinical counselor, a psychiatrist, a spiritual counselor. There are ways to get some assistance for yourself, right? And so if you have depression or another behavioral or mental health issue that's disrupting your sleep patterns, these really need to be addressed, and they should be addressed by a specialist. Seeking out substance abuse issues, if you have substance abuse issues, seek out some help for that. And that includes smoking, that includes excessive drinking, and it includes your prescription medications if you feel that you're abusing those. So you may need additional help for that, and we don't want to discourage anyone from getting that help that they need. That being said, it's so incredibly important to be gentle with yourself, right? Create a peaceful bedtime ritual. Know that this may take some practice. And can you please mute yourself, whoever is talking? Thank you. Be gentle with yourself. It's so important to realize that this will take some practice. Insomnia sometimes kind of builds. We get into negative cycles and negative habits and negative patterns. And if we can create some positive cycles and patterns, we can it's important to let it take some time if it needs to. If you can listen to relaxing music or take a warm bath or a foot bath close to bedtime, you might find that as a helpful ritual. One of the things that I find that people say is that they can't shut their mind off. And when they can't shut their mind off, one of the techniques that I suggest to people is that you just write, take a piece of paper and write all the things that are on your brain. These may be unaccomplished tasks from the day that you think that are just filling your head right now. Just write about these, about what's on your mind. And then, don't worry about punctuation or capitalization or anything like that, because you're just going to throw it away, right? But it's to get it out of your brain. Another thing you can do is take a task that you know really well. And while you're lying in bed, if you find that yourself kind of perseverating about your sleeplessness, take a task that you know really well and just go through it mentally, item by item. Maybe it's a favorite recipe. Maybe it's changing the oil in your car. If you had a car that you could change the oil in, it would have to be a classic car because it's impossible to work on cars these days. But anyway, take something that you know really well and go through it item by item in extreme detail. And sometimes that can push out these unhelpful thoughts that are just going round and round in your head about undone tasks or something that you're finding yourself having anxiety about. And sometimes that can be really helpful. So that's probably, if I was to meet one-on-one with you, I might have some additional tips for what might help with your insomnia if I knew exactly, what things were keeping you up. But in general, I think that these are really helpful tips. Oh, one thing I didn't say about good sleep hygiene is that the recommendation is that you make your bedroom and your bed appealing and appropriate and use it only for sleep and sex, and not for doing other things. And your bed should not be for doing other things, and because that does sort of set the pattern for you and for your brain that the bed is for sleep. Next slide, please. All right, so dealing with anxiety and depression, I put them together on this slide because really they are frequent bedfellows, right? They're found together and they exacerbate each other. right? I could probably spend a whole hour talking about either one of them and barely scratch the surface. But what I'll do is discuss these and hopefully provide some helpful information and that supports, patients who are dealing with them. And first we'll do anxiety. Next slide, please. So general anxiety, for our purposes here, we'll define that as a feeling of worry, nervousness, or unease. And it's most typically about something that's going to be happening, about something with an uncertain outcome, right? So for some people, it's a doctor's appointment or a test that is coming up. They might find themselves having some anxiety about that. And so we're talking about general anxiety here. Now, when we're talking about anxiety disorders, that's different. There are a number of anxiety disorders, and there's, really no reason for us to talk about all of them here, but just to have a sense of what some of those anxiety disorders are, I think it is helpful to talk about them a little bit, right? So, so it might be that the anxiety disorder that a person is experiencing is panic disorder, or they may have a social anxiety disorder, or they may have a phobia. They may have a sort of post-traumatic stress disorder. And so there are different types of anxiety disorders, and typically those people who are experiencing those have frequent, intense, extreme, and persistent worry and fear about everyday situations as they relate to the particular kind of anxiety disorder they have. And there can be anxiety that is directly caused by a medical issue. For our purposes here, we're really going to be talking about general anxiety. And but if you're diagnosed with an anxiety disorder, you may have this frequent, intense, extreme feeling, and that can be the same when you're having an illness induced or an illness related issue that is creating anxiety. Diabetes can, and thyroid problems, heart disease, COPD. There are sometimes if somebody is misusing medications or withdrawing from medications, that can be a medical problem. It's not always related to an underlying condition. Anxiety can be caused by stress related to work or a personal relationship or things that are just outside of your control. Having things be outside of your control and unknown can be enough, right? And but like I said, for our purposes here, we're going to be talking about anxiety. But first, I want to talk about fight, flight, or freeze. So next slide, please. So if we look at the graphic here, this is a lot of sort of medical terminology, but the long and short of it is that when we get triggered, the hypothalamus in the brain activates both the sympathetic nervous system and the adrenal cortical system, right? So this adrenal cortical system releases CRF, which is a hormone, and that stimulates the pituitary gland to secrete ACTH, which is also another hormone. And then when they reach the adrenal cortex, they release, approximately 30 hormones, right? Then on the other side, at the same simultaneously, the sympathetic nervous system is being activated, and that affects the glands, the smooth muscles, and the adrenal medulla. And what ends up being resulted is norepinephrine and epinephrine. And epinephrine, the other word for that is adrenaline, which we're all sort of familiar with, right? So the combination of all of this creates this fight or flight response. This is a normal, natural response, and everybody has it to some extent. I just listed a few of the body responses that people can experience. I tend to identify it like that feeling that the phone just woke you up out of sleep, right? that feeling, right? A heart rate, your heart rate rises, blood pressure increases, your skin may be flushed or pale. You have a feeling of being on edge or tense, right? You can have a feeling of agita, your digestive system can get all whacked out. Loss of bladder or bowel control, and your respirations may be rapid and shallow. The reason I'm focusing on this and the reason I took the time to really talk about the fight or flight response is that it is an incredibly important response that is found throughout the animal kingdom. Here is the problem. Human beings have a wonderful sort of double-edged sword of being able to perseverate about the past and project, usually negatively, about the future. And this can keep us in this fight or flight response, even when there is no danger, right? There is no danger, there's no monster under the bed. We can, depending on how we relate to situations, we can keep ourselves in this constant fight or flight response. Pardon me, I'm just going to take a drink. So we all have times when we feel somehow, threatened, and that feeling of fight or flight can come up. But in the animal kingdom, as soon as the predator is gone, animals rebound much quicker from this fight or flight response, right? It's a really natural response, but they are dealing, in the animal kingdom with actual crises, with an actual danger. Whereas human beings, sometimes we're really not dealing with that, but a perceived danger, or we're being triggered from a past experience, right? So next slide, please. So anxiety can really have a lot to do with how we are responding to situations, right? I am not saying that it isn't something physical and real, because it is. We have that fight or flight response, right? But in order to cope with that anxiety, my suggestions are, right, to seek professional and therapeutic help, right? Either a psychiatrist, a therapist, but we want to, my encouragement is to do this early. Anxiety can get harder to treat with waiting, right? Trying to wait it out may not be the best strategy, right? Getting regular exercise is a way to help the body deal with some of that body chemistry, but it's also really good for you all around, and it will help with anxiety, right? Getting enough sleep and eating well-balanced diets. Again, here it is again, that same kind of thing, right? Maintain a positive attitude to the extent that you can. Now, that doesn't mean that, that you're not going to have bad days. And it doesn't mean that there won't be moments when you're going to need to just sort of feel your feelings and vent to someone and be upset about something that's going on. But when it passes, let it pass, right? And then try to go back to maintaining, a more positive attitude. People do tend to cope better with life in general and with anxiety and depression when they're able to come at things with a positive attitude, right? Learn what triggers your anxiety and what works to alleviate those triggers. What triggers anxiety for people is going to be different, for everyone. Something that makes someone else anxious may not make you anxious at all, and vice versa. But suffice to say that it's important to have as many tools in your toolbox as possible, because what works for somebody else to help reduce their anxiety may not work for you, because the triggers may be different. And what worked for you one day to help reduce your anxiety might not be enough, to help you the next time something happens. So having enough tools in the toolbox is going to be helpful. Practicing relaxation and mindfulness techniques, and I would include here grounding techniques. And what I mean by that is trying to do those things that bring you back into the body and out of the mind. And we'll talk a little bit about that when we talk about the two more modalities for anxiety, right? And if possible, stop smoking and consuming caffeinated drinks. And there are other things that, that also increase anxiety. I had somebody say to me, I smoke because it makes me, it helps relax me. Well, it's probably the behavior of smoking that is relaxing you, but it's not the nicotine, because that's a stimulant. Next slide, please. Okay, so 2 modalities for dealing with anxiety and, helping to reduce it and helping to manage it, right? Cognitive behavioral therapy, or CBT, and dialectic behavioral therapy, DBT. So we're going to go through these, we're not going to spend a whole lot of time, but I'm going to talk about these because these techniques are really the most helpful in dealing with anxiety. Next slide, please. So this graphic sort of says it all, right? Behavior impacts thoughts, thoughts impact feelings, feelings impact behavior, and so on, and so on, and so on, right? So this can kind of go around like in a circle. It's important when using cognitive behavioral techniques, and a therapist can really help you with this, and will probably give you some homework about those things that you are kind of fueling your anxiety, right? Identifying the source of your anxiety at any given time, and you may have various sources, but being able to identify those, really look at those. What are the things that you're worrying about? What are the things that that you feel uncertain about, right? So identifying those sources, right? Identifying negative beliefs that you have about yourself and the situation. Identify the negative thoughts that strengthen the anxiety. So those negative thoughts can also be thought of as, cognitive distortions. That's one of the terms for them. They could also be thought as limiting thinking patterns. And I'll just name a few here, but, all or nothing thinking, where there's no gray, where you're not able to see any gray, is one example of a cognitive distortion. Overgeneralization, where you make a decision and you have a reaction based on one experience, but you generalize that to every experience that's like that. Personalizing, over-personalizing something. That's when, we feel like whatever's happening, whatever other people are doing, it's a reaction to something to us. And I like to say to people, they're not doing it to you, they're just doing it. And that leads into another cognitive distortion, which is mind reading, where we think that we know what somebody is thinking, what they're thinking about us, what they're thinking, or what their motivation is for for behaving however they're behaving, right? So those are some cognitive distortions, and they can really strengthen our anxiety. And what we want to do is be able to challenge, in CBT, what we want to do is be able to challenge those negative thoughts, to challenge our kind of automatic thinking that tends to sometimes, be on the negative. When we challenge them, we want to do a little truth testing, right? If our automatic thought is, this cancer is going to kill me, and that's what gets triggered every time, we see a commercial on television. So challenging that would mean, is this what my doctor is saying to me? Is this what my lab work is showing? Or is it just the way that I automatically think, right? Through this process of, going through this strategy for dealing with anxiety using cognitive behavioral therapy, it's so important to just remember to breathe, to focus on your breath, breathing deeply, and allowing yourself to sort of just let your shoulders down is one way to combat the feelings and emotions and the body chemistry that comes up during fight or flight, right? And so remember to breathe. Remember too that you're dealing with anxiety, and that anxiety is not, it doesn't control you, it's a feeling, and feelings are not facts, right? It's important to keep that and to develop a balanced thought that realistically looks at the situation and is able to maybe a bit more objectively see what's really going on, right? And then examine the results. So at the end of the situation that maybe you had a whole lot of anxiety about, was it the case that that it turned out the way you thought it was going to turn out? Or were you able to sort of mitigate some of the feelings about that? And did it maybe turn out better than you thought because you were challenging some of your beliefs and some of your cognitive distortions? So again, a lot more could be said about about CBT, but that's sort of a first blush. Now let's look at DBT. Thank you. Okay, so again, there are some things that are going to be really helpful in dealing with anxiety, and so the dialectic behavioral tools are diaphragmatic breathing. So this is a type of breathing where you emphasize a longer exhale, right? So you can inhale to a count of 4 and then hold, and then exhale to a count of 8. You want to have a longer breathing. And again, part of what we're trying to do here is counteract some of those symptoms. And those symptoms are ones that, there's not a lot that we can do sometimes about things that happen, but then how we address them. And so breathing is one way to sort of take, that breath is always with you. So to take the moment back, right? Manage the source of your anxiety and stress if you can. And so this interpersonal effectiveness technique, this is a form, it has its own acronym, right? So it's Dear Sir. And what Dear Sir stands for is describe. So describe what it is that you want when you're dealing with somebody else, using being clear in your words and making sure that you're being understood and minimizing misunderstanding. So describe what it is that you want, express your feelings and opinions about the situation, assert yourself by asking for what it is that you want clearly and politely. Don't assume that other people know what it is that you need or want. Try not to be aggressive and not passive or passive aggressive, right? Reinforce and stay mindful, right? And appear confident and be willing to negotiate. So that is, those are some of those interpersonal effectiveness tools that can help you in situations where you may have some anxiety about getting your needs met, where you may have some anxiety about some sort of confrontation, right? Self-soothe. And here, engaging as many of the senses as possible, right? Engaging vision, touch, hearing, taste, smell, do things that engage your senses. And this will take you out of that really circular brain and back into your body, right? Make sure that you manage sleep and get enough of it without oversleeping. Practice mindfulness on a regular basis. And again, we've talked about that a little bit, but at any moment when you feel like you just kind of have to get grounded, you don't have to go outside to put your bare feet in the grass, although that does help. But you can take a moment, let me name some things I can see. Let me name some things I can smell. Let me name some things I can touch. Get into the body and out of the head, right? And don't forget that there are things that you do well. There are things that you have mastery over. And so it can create a sense of confidence to do something that you know that you do well when you're dealing with anxiety. Exercise, again, can be a huge benefit, even just, like I said, a short walk. Engage in activities that require thought, such as a hobby or puzzles or something that's mentally challenging. And again, you're trying to use your brain differently than letting it sort of run away with anxiety. Engage, focus on yourself. Consider how you can help other people and thus take the focus off of yourself. You know, when we're focusing too much on ourselves, again, it can create this vicious cycle. And it doesn't have to be formal violence volunteering. It can just be doing something nice for someone in the moment. How can I help another person, whether that's through mentoring or just being present to another person or letting someone else vent to us. That can be helpful in taking the focus off yourself. And planning activities, enjoyable activities on a regular basis. These are small things that we can do, and you can plan small activities, you can plan larger activities, but make sure that you're building in some enjoyable and fun activities to help you sort of counter that anxiety that you're experiencing. Next slide, please. And finally, we're going to be dealing with depression, right? So I don't want to give depression short shrift, but you know, it can be classified as a mood disorder, described as these feelings of sadness, loss, anger that impact a person's daily life, can impact their motivation, can impact their mood, their appetite, their sleep patterns, can their activity levels, their thoughts, and again, you know, their motivation. Major depressive disorder, this is a very specific type of depression. And again, there are certain criteria that have to be met according to the DSM-5, that's by the American Psychiatric Association. But most people, you know, when we're talking about depression in this kind of setting, we're really not talking about major depressive disorder, but, you know, this can be co-occurring with other things. It affects how you think and how you feel and how you behave. So it's important, really important to seek immediate medical attention if you find that you are having feelings of hopelessness, feelings that life is potentially not worth living, right? Don't wait to call a physician or a mental health professional when you're feeling some strong depression that impacts both you physically and behaviorally, impacts your daily life, makes you feel potentially like a failure. Make sure that those kind of feelings don't go unchecked. You really do need to get professional help as much as, you know, as soon as you can. And if you need help with those resources, I can certainly give them to you. Next slide, please. So symptoms of depression, right? Feeling tearful, feeling an emptiness or sadness or hopelessness, some overblown irritability, frustration, angry outbursts, some, you know, taking the dog kind of syndrome. When we don't feel ourselves, when we feel off, we can have a loss of interest or enjoyment in normal activities. Issues with sleep, including sleeping too much or having insomnia, can certainly are related to depression. Reducing or increased appetite or weight loss or weight gain, right? So a change in appetite can be, you know, a symptom of depression and shouldn't be taken lightly. Unexplained somatic complaints, right? So physical aches and pains. Sometimes just we don't necessarily always associate depression with physical complaints, but there really can be things that are somatic complaints. Depression can also come from, you know, experiencing trauma, as can anxiety. So depression does need to be taken seriously. Difficulty thinking, concentrating, making decisions, remembering things, engaging with other people on a regular basis. These can be symptoms of depression. And frequent and recurring thoughts of death, suicidal thoughts, suicide attempts. But, you know, again, no thought of that life is not worth living should go unchecked without talking to someone. And hopefully, you know, seeking appropriate medical assistance or therapeutic assistance or both. Next slide, please. So some common causes, brain chemistry, right? You know, there are also inherited traits that can cause depression, and biological differences, hormones. There are imbalances that drugs seek to address. But there also is, you know, a genetic predisposition for some people, you know, to have depression. Risk factors would be, again, a history of trauma or stressful events, And certainly unresolved trauma is a big issue to, to look at if you're suffering from depression. Having a blood relative with a history of depression, alcoholism, suicide, or bipolar disorder. Again, there are some brain changes with individuals that we don't necessarily understand completely, or I don't understand completely, but I do know that it can have, an inherited aspect to it. Having low self-esteem or overdependence or self-critical or pessimistic personality traits can lead to depression. They also lead to, difficulty in interacting with other people, which can lead to isolation, which can also lead to depression, right? Being part of a marginalized population, any number of marginalized populations, but not to exclude being gay, lesbian, transgender, or gender non-conforming, non-binary, or intersex can certainly, be a risk factor for depression. Alcoholism, substance abuse, including, prescribed medications, serious chronic illness, including heart disease, chronic pain, stroke, and cancer. History of other mental health disorders, including anxiety disorder, an eating disorder, PTSD, and others that, aren't mentioned here. So taking certain medications or withdrawing from certain medications can be a risk factor for depression. Okay, so next slide, please. So getting some help. I know that these were reviewed pretty significantly with Dr. Habib, right? So SSRIs, increasing the serotonin levels in the brain, which is known to control emotions, and some typically less side effects with the SSRIs than with the SNRIs, right? And so these medications have some more side effects. The serotonin, norepinephrine reuptake inhibitors, and tricyclic medications. These are antidepressants that actually have been shown to be very effective, but have some more severe side effects. And so they're not typically going to be used unless you don't really respond to the other medications. Therapy, psychotherapy, talking with someone about what's going on. Talk therapy and medication has been shown to be one of the best combinations for dealing with with depression, far better than just one modality alone, just medication or just talk therapy. So talking about the condition and the related issues, with a mental health professional. And again, there are a number of mental health professionals who can help you dealing with your depression. They can help you detect what thought patterns, what behavior patterns, what negative self-beliefs, and they can also assist you in what tools might be helpful in pinpointing some of the environmental causes, of your depression, or the internal causes of your depression. They may suggest some journaling or some activities that you can do outside of therapy that will provide some coherence for the therapy so that you don't lose ground in between sessions. It may be helpful for the therapist to include some learning exercises that help you find your levels of stress and how to reduce that stress and anxiety and enhance your understanding of depression. Again, anxiety and depression are frequent bedfellows. And a therapist can also help you come up with strategies that are really pinpointed to you and help with your specific triggers that exacerbate your depression. And they can also help you develop some coping mechanisms when you experience these triggers. There's probably, like I said, a lot that could be said, but again, we have a limited amount of time, but I wanted to provide as much information as I could. Next slide, please. And so self-care for depression, right? Meet yourself where you're at. Do not be too hard on yourself. It's incredibly important to be realistic and just look at where you're at, right? Have your feelings, but don't follow them down the rabbit hole, right? What you resist persists. So if you resist having your feelings, they're going to persist. Have them, but don't hold on to them. Have them and let them pass. They may come back again, but have them and let them pass, right? Avoid cognitive distortions, like I'm always going to feel like this, and every day will be like this one. Make sure that you're looking at individual parts. Don't fall into overgeneralization. Don't look, lump everything together. My life is horrible. It's never going to be better. Wait, there are always positive things that can be looked at, right? Do the opposite of what that negative, irrational voice in your head suggests. Set attainable goals and reward your efforts when you meet those attainable goals. Create a routine, and do something enjoyable. Don't make everything dull and dreary and work like when combating your depression, right? Use music to boost your mood, connect with nature. That can help a lot of people. Spend time with those who you love and they love you and you feel safe with them. Engage in something new. Again, get out of your comfort zone. That can actually help kind of bang that record, get out of that rut, that groove. Practice getting outside of yourself. Practice doing something good for someone else, maybe without even letting them know. Practice gratitude. The gratitude practice, even maybe making a gratitude list every day, can help a lot with depression. It's again, that it's a practice. Incorporate meditation. Again, this is a practice, and if it's something that you're interested in, I can provide some more information about that. Get enough rest. Engage in active lifestyle. Make good food and drink choices. Take it one day at a time, just for today. Getting through this day, especially if your depression is profound and you are getting help. Just deal with this day as best you can. And remember that life is worth living, and you're important. No matter what might be going on in the moment, whatever situational experience you might be having, life is worth living. Okay, next slide, please. Thank you so much for attending today. And I guess we'll look at the questions. I hope I didn't go too far over. Oh no, 6 minutes. I'm really sorry. But some people are still hanging on. I see that there are 10 participants. So let me look at what is here in the questions, and I will do my best now.
Can you see them or do you want me to read the
I can.
questions?
Hold on.
Okay, great.
Yeah, I just wanted to address the effects of the pandemic on cancer patients and caregivers. Diagnosis occurred in July 2020. Surge into chemo subsequent to that pandemic, I feel, has made my healing extremely difficult. Cynthia, you are not alone in this. The pandemic has had profound effect on everybody, and I think it'll be a long time before we know all of the aspects where people have been impacted. But just in general, having the potential, having to potentially put off what might have been seen as an elective surgery, maybe not being able to see the doctor exactly when your symptoms first started, or being able to start your treatment at a time that was optimal because of everything that was happening in the healthcare system and happening with the pandemic. Needing to come and be screened every time you come, not being able to bring your loved ones who are part of your support network with you. Those are just a few things that impacted people as they were going through their treatment. So I don't disagree. I think that having gone through this, especially being sort of newly diagnosed, I'm sure this impacted your cancer treatment, your cancer diagnosis, your mental health, and impacted your loved ones as well. Okay, so the next one. How long does Chemo Brain last after you're done with chemo? Well, I do think that Dr. Habib addressed that to some extent. It really differs for everyone. And it differs related to the person, the individual, but it also differs related to, your individual physiology, right? And sometimes some people work at it differently and are able to come up with strategies for working with the chemo brain that helps them quicker than other folks. And so, unfortunately, it's variable. Okay, people saying they have to go. How to find a therapist. So yes, I think that there are a couple of good ways to find a therapist. One, you can reach out to your insurance company and talk with them about, who is in the area. You can also go on a website that's called Psychology Today, and you can plug in your address or your zip code, plug in, that you're looking for a therapist, and you can actually sort out through what kind of insurance they take, whether it's a male or female, whether or not they speak a different language. And you can come up with a list of potential therapists that way. Also, don't hesitate to reach out to the social worker that is your social worker here at the Cancer Institute. And again, my email is on the first slide. But I do think that it's important to get sort of a list and work from that list, make phone calls and see if you can make a connection with someone, see if they have, sometimes people have complimentary phone sessions to see if you can make it a connection. You want somebody who's going to, that you're going to feel comfortable with, and that there can be a connection there, because you're going to need a therapeutic alliance with that person. Okay. It is not the case that most therapists don't accept insurance. Some do, some don't. Some accept what's called, your out of network benefits. And so then you pay, and when you submit the bill for therapy, you get back what your insurance is willing to pay as an out of network benefit. Not necessarily optimal, but if you find a therapist that you really connect with and you feel like you're going to do good work with them, it can be worthwhile. Can Chemo Brain result in possible dementia? I don't know the answer to this. This is really a medical question, and I'm afraid I don't know the answer to this. Those are two different things, Chemo Brain and dementia. Whether or not Chemo Brain can exacerbate the onset of dementia is something that, again, I don't know, but I do think that Dr. Habib would be better to answer that question. But ask your oncologist. I do think that it's a valuable question. Patient who's experienced Chemo Brain, working cognitive challenge position, not prepared for a challenge. Oh, that one I think we answered already. Have we gone through all the questions, Alicia?
Yes.
Okay, awesome. Are there any questions for the people who are still on? Because I value the fact that you stayed on, even though I ran a little bit late.
Yeah, feel free to unmute yourself.
No? Okay. I hope that I brought some valuable information. I hope that the presentation, both from Dr. Habib and myself, provided some information that can assist you in dealing with, Chemo Brain, insomnia, depression, anxiety. Do not hesitate to reach out to the social worker, that is connected to your tumor study group. Also, ask your doctor who your social worker is if you don't know. And if you work here and you're attending, stop me in the hall if you have a question, and I'd be very happy to answer it.
Rose, would it be okay if I shared your slides?
Yes,
Okay,
I am totally fine with that.
I'll do that. I'll send them in an email after.
Okay. Thank you so much for everybody for taking this time out. And I also want you to sort of give yourself a pat on the back for, for being proactive in learning about, these really important topics and trying to educate yourself a little bit about what might help. Okay.
Thank you, Rose. Thank you, everybody. I'll send a follow-up email. Thank you.
Thanks. Okay. Bye-bye.
Bye.
Alicia, what'd you think? Go okay?
Oh, can you hear me?
Yeah.
I think it was good. I think Dr. Habib took a lot of time, and he did send us an email just now saying he won't be so blabby next time.
That's okay. That's okay. That's okay. I mean, it's, it's
a
not
lot
that
of information.
It is. It's a lot of information. And, again, I think that any one of these topics, you could spend a lot of time on.
Yes. I think
And-
people want more specifics on Chemo Brain rather than insomnia, anxiety, depression. I see a
Right.
lot of people logged off.
Right, and that's
we-
really
yeah.
fine. You know, people have different reasons for coming on and but I hope that it met the expectations of people for the most part.
Do you think that we could do something in the future with regards to Chemo Brain and maybe have some patients come on and
Oh,
talk
I don't
about
think
their
that's
experiences?
I don't think that that's out of the question at all. I think, you know, talk to Dr. Habib about that. I think that
Yeah.
that's a reasonable thing. You know, I would like to actually have somebody who's gone through, you know, like cognitive rehabilitation, be able to share their experience with that, because it's not necessarily the kind of
Mhm.
thing. Sometimes we poo-poo Chemo Brain because, you know, people, you know, we're always told that the chemotherapy doesn't pass the brain blood, you know,
Mhm.
barrier. But that doesn't mean that this chemo that we're putting through people's bodies doesn't affect, you know, we know it's not just the brain that is responsible for feelings and thoughts and, you know, and reactions. You know, the brain obviously is something to do with it, but there's lots of good information about the reality of Chemo Brain, and that it's not just, you know, in somebody's head.
Yes.
So to speak.
Yep. Yep.
So
So
again, I hope
do you
that
know
it-
anybody who's gone through the cognitive rehabilitation?
not for Chemo Brain. I know people who have gone through cognitive rehabilitation for, you know, slips and falls. And, you know, I worked a long time ago with a chaplain in hospice who slipped in the bathtub, and she, you know, she went through quite a bit of cognitive rehab.
Mhm.
So I know that it, you know, can be really helpful. I just don't know any patients who have gone through it.
Maybe Dr. Habib might.
He might. All right, so I realize now we're still recording, so.
Oh, yeah.
I
Oh
guess,
my gosh.
is it possible to eliminate some of that recording?
Hold on.